to start?
Welcome, everybody, dear colleague, dear students, dear friends. Welcome to our Mustafa Cardiology webinar with the expert. Today is Monday, February 24 to 2025. We have the pleasure to welcome today Professor Wilfried Mullens. First of all, I'd like to extend my sincere thanks to our distinguished guest, Professor Wilfried Mullens, from a leading cardiologist from Hospital Oost-Limburg, I think, Belgium. Professor Mullens, we truly appreciate you taking the time to share your expertise on heart failure. We are delighted to have you with us today for this webinar. The topic will be the title, what is the best strategy for heart failure decongestions in clinical practice? This session will be moderated by Professor Melkowar, our friend, who will guide the discussion. Everybody, please feel free to ask your questions in the chat at the end of the conference, or to speak during the Q&A session at the end. Once again, thank you, Professor Mullens, for being with us today. Professor Melkowar will now introduce our guest and chair this session. Riyad, the mic is yours. Riyad, if you
Thank you.
Thank you.
Thank you. Thank you, everybody, and welcome to this exciting webinar entitled What's the Best Strategy of Heart Failure Decongestion in Clinical Practice, which will be presented by a distinguished speaker, my friend and Professor Mullens, Wilfried Mullens, who is a cardiologist specialized in heart failure in the Hospital Oost-Limburg, Genk, Belgium, and he's a professor of cardiovascular physiology at Hasselt University in Belgium. So his main research topics are diuretics in heart failure decongestion, and he was published a very nice paper, position statement about the use of diuretics in heart failure from the Heart Failure Association of the European Society of Cardiology, and as well as other main topics about cardiorenal syndrome and also cardiac resynchronization therapy. So he's been president of the Belgian working group of heart failure, and actually he's the president-elect of Heart Failure Association of the European Society of Cardiology. So I invite all of you to participate actively in this webinar by sending your questions and comments via the chat. And let's begin with this webinar. So I address to Wilfried. Please, can you start the presentation?
Merci Riyad pour l'invitation. Et c'est un honneur pour moi de donner cette exposition du Decongestion. Je vais parler anglais, c'est plus facile pour moi, mais vous pouvez demander votre question en français, ça va aller, je crois. Alors, I'll try to explain to you what you should do in case of diuretic resistance or when you see the kidney function going down. And this is not a problem, this is just a normal physiological response to heart failure. And I'm going to start with my conclusions. First of all, chronic kidney disease is very prevalent. It's very prevalent, and it's related to adverse outcomes much more than ejection fraction. Secondly, renal function is a lot more than GFR. GFR is just part of what the kidney does. Third, you have to understand that natriuresis, so getting rid of sodium, is way more important than aquaresis, getting away with water. Fourth conclusion, diuretic resistance or worsening renal function is not a problem. It's just a normal physiological response to the insult of heart failure. And five, never ever stop decongestion. So don't stop diuretics if you still have congestion, and don't stop guideline-directed medical therapy if you see worsening renal function occurring. So let me try to explain these conclusions. The first one is renal function is more than GFR. GFR is just a filter, it's the filtration, but what is more important is the tubular function. So what happens to the fluid once it's filtered, and that is determined by the tubules. So when you measure GFR, you're only measuring part of what the renal function actually is. You should also measure what's coming out, what do I mean by that? Well, you should also measure the urine quality. Bear in mind that everybody loses GFR once you reach the age of 50. You lose about 1 ml per minute every year you age. This means that if you're 50, that you will lose around 50 mLs if you become 100 years. That is still enough to live without dialysis. However, if you have heart failure, there's an acceleration of nephron loss, and therefore you might end up in dialysis. So you have to do everything you can to give patients with heart failure the right drugs to prevent this decline. We have RAS inhibition, we have ARNI, we have SGLT2. All these agents actually lower down the decline in GFR. And it's very important that you give these agents to help improve prognosis of your patients. If you measure GFR, that's good. You measure that either via serum creatinine, and GFR, the lower it is, the higher the likelihood will be that you will end up with heart failure. But bear in mind that GFR is not the only prognosticator. You should also measure the urine albumin creatinine ratio. And this is just done by taking a urine sample. If you lose more proteins in your kidney, you also have a worse prognosis. It's just take a urine sample and send it to the lab. There are many patients who have a normal GFR, but still have proteinuria. So you have to measure this, because if you see proteinuria, there's a clear benefit of adding agents like an SGLT2 to lower down the decline in GFR. Let me ask you a question. If you would drink 1 liter of water, or you would drink water with some sodium in it, so isotonic solution, when do you have to go to the toilet most rapidly? Most people probably think that you have to pee faster if you drink sodium, but that's not correct. It's very difficult for our bodies to lose sodium. It's very easy for your body, for your kidneys to lose water. Why? Because if you drink water, your brain starts to swell and your body doesn't want that. So it's easy for your body to get rid of water. It's difficult to get rid of sodium. The only patients that have difficulties of losing water are the ones with advanced heart failure, because they have a very high ADH secretion. ADH is the same as AVP. That means that once your oncotic pressure starts to rise, that you're going to secrete an agent which will maintain water. And this is easier if you have a higher angiotensin level. So only patients with advanced heart failure will also retain a lot more water. What is the reason that we have this sodium and water retention? Well, you have to bear in mind that most patients, they have, I'm trying to get rid of this, I'm sorry. So most patients, they have more sodium retention than they have water retention. So that is also the reason why it's more important that you improve natriuresis than diuresis. Because if you have heart failure, you retain more sodium than you retain water. How much sodium can you lose in your urine? This is an experiment done in the United States where they forced soldiers to eat a lot of sodium. And then you can see that the sodium concentration in the urine can be maximum of 280 millimoles. Your normal serum sodium level is 140 millimoles, so you can actually have a higher sodium concentration in your urine than you have in your plasma. However, if you have heart failure and you give people diuretics, the urinary sodium concentration will always be lower than the serum sodium concentration. This means that you need water to excrete sodium if you're faced with a patient with heart failure. So you cannot lose more sodium in your urine if you give diuretics than the serum sodium concentration. Why do people with heart failure have a tendency to retain more sodium? Well, this is linked to the RAS system. We have a very high RAS activity, and that means that we're going to retain all the sodium that we eat in our gut. You cannot lose sodium in your gut. It's very difficult to lose sodium in your gut, and it's also very difficult to lose sodium in your kidneys. And a normal kidney filters a lot of sodium. A normal kidney filters around 1 kilogram of sodium per day. 1 kilogram. And even if you have a low GFR, you still will filter a lot of sodium, up to 150 grams sodium per day. So the filter is not the problem. The problem in the kidney is the reabsorption. And bear in mind that you filter around 100 mLs of water and sodium per minute, and you're only going to excrete 1 ml of water and sodium per minute. That means that what you filter is going to be reabsorbed along the tubules. And most sodium is reabsorbed in the proximal parts of the kidney. This is even worse if you have heart failure. So you filter a lot, but you reabsorb almost 99% of what you filtered in the tubules. And most of it is reabsorbed in the proximal parts of the kidney. So bear in mind, you filter, yes, but you reabsorb almost everything, especially in the proximal parts of the kidney. We recommend in our guidelines that you have to make sure that you get congestion out of your patients before you discharge them. Now, an organ that you need to get rid of sodium is, of course, the kidneys. And the kidneys are very susceptible to high central venous pressure. So if you have a high central venous pressure, you have a very high likelihood that you will see worsening renal function. Why is this? Well, it's the outlet. So you need flow to the kidney and you need flow to get out of the kidney. So if you have a high central venous pressure, then you actually will have a reduced renal blood flow, and the reduced renal blood flow will lead to worsening renal function. Bear in mind that a normal kidney gets around 1 liter of blood flow per minute. So if you have a high central venous pressure, you also will have a reduced renal blood flow. We recommend to give IV diuretics to everybody with signs and symptoms of fluid overload, and we recommend to give thiazides in patients who do not respond to loop diuretics. Is this correct? Well, first of all, most patients, if they are already on a loop diuretic at home, they will not respond really well to IV loop diuretics. If you don't take diuretics at home and you give somebody 40 milligrams of furosemide, they should pee around 3 liters of water and sodium. And almost none of our patients is actually doing that. The second problem, if you only give loop diuretics, so no additional drug, but only loop diuretics, is that you will have some urinary volume over consecutive days, but the quality of the urine is changing. What do I mean by that? Every day you give loop diuretics, the sodium concentration in the urine will go down. So on day 3, you can get rid of water, but you can't get rid of sodium anymore if you only give loop diuretic therapy. In order to improve the use of loop diuretics, we put forward this position statement a couple of years ago, which Riyad was referring to. It's a very highly read document. More than 500,000 people have read the document so far because it has a lot of practical flowcharts. Let me explain it to you. First of all, door to diuretic time. What do I mean by that? If you're faced with a patient with congestion, just give the IV diuretic as soon as you see the patient. There is no reason to wait for anything. Just give it to the patient as soon as you see him. How much loop diuretic do you have to give? Well, we always promote to give a bolus. And if the patient is loop diuretic naive, meaning he's not on furosemide at home, you give 40 milligrams IV bolus. If he is already on a loop diuretic, you give twice that amount. So you give 80 milligrams if they were on 40 milligrams. If they were on 80 milligrams, you give 160 milligrams IV bolus. So that's the starting dose as soon as you see the patient. Then you have to evaluate the effect of the loop diuretic. How do you do that? The first time the patient pees after you gave the loop, you send it to the lab and you measure the urinary sodium concentration. And that should be at least 70 millimoles. So you take the sample, you send it to the lab, and you measure the sodium concentration. And that should be at least 70 millimoles. If you don't want to measure the urinary sodium concentration, you measure the urinary volume, and that should be at least 100 cc's per hour. It's far more difficult to measure urinary volume because patients don't want to have a Foley catheter anymore. So it's easier to just measure the urinary sodium concentration. Why do you have to do that? Well, if they don't pee 100 cc's per hour, or if the urine concentration is too low, you have to double the loop diuretic already after 6 hours. So you have to change the dosing of the loop diuretic if patients don't respond well enough to your first dose. If they, however, respond well, meaning they have a more than 100 cc's per hour urine output, and their urinary sodium concentration is above 70 millimoles, then you give the same amount of loop diuretic therapy twice a day. You only stop when the patient is dry. You don't stop loop diuretics or another agent before your patient is dry. Again, this points out to the importance of having a negative sodium balance. You can have a positive urinary volume loss, so meaning you lose more than you drank, but if you don't lose sodium, your patients will come back to the hospital. So you have to make sure that people lose sodium before they lose the hospital. If you don't believe me, well, there are many trials now which have been performed all over the world showing that if you use this urinary sodium guided approach, that you can improve the amount of volume that you can actually get out of the patient. ENACT was a prospective multinational study. There was also a center in Algeria participating in this study. PUSH-AF was a single center study. Both of them were measuring urinary sodium to guide diuretic therapy, and both of them showed that you can get a lot more out if you just measure urinary sodium and you change your diuretic dose. If you don't want to send that sample to the lab, now you can also use a point of care urinary sodium sensor. This is a sensor that my nurses use nowadays. They just measure the urinary sodium bedside with that patient, and then they change the diuretic dose. So the nurse does this. And if your nurse actually has this sensor, she or he can change the diuretic dose and therefore get more patients dry at the end of the hospitalization. What do you do if you see worsening renal function? So worsening renal function means your serum creatinine goes up or your GFR goes down. How do you approach this? Well, first of all, worsening renal function does not lead to permanent renal damage. If you see this if you see worsening renal function occurring, this is not accompanied by true renal kidney failure. If you have a very high NGAL level, that would mean kidney failure. This never happens if you have worsening renal function during acute heart failure. So don't worry too much. How do you respond to that? Well, if you see worsening renal function occurring while you're giving diuretic therapy, what do you do? First of all, you have to assess the diuretic response. So you need to know if that patient is responding well to your diuretics, if he has enough urinary sodium concentration, or if he's peeing enough. If the diuretic response is good, I don't care about worsening renal function. So if I see serum creatinine go up and I have a good natriuresis, I just continue my decongestive efforts just like I was doing before. I just don't care anymore. However, if I have a poor diuretic response, meaning urinary sodium below 70 or urinary volume below 100, then I have to make sure there is no hyperperfusion. Hyperperfusion means shock. Shock means inotropes or mechanical circulatory support. But shock is extremely rare. Less than 1% of our patients have shock. Most of the times, they just have a poor diuretic response. And then you have to do two things. First of all, increase your diuretic intensity. And secondly, consider IV vasodilators. Why vasodilators? Because pressure is not the same as flow. My kidneys want flow. They would like to have more blood going to the kidneys. They don't need pressure, they need flow. You can increase pressure by giving levofed, by giving norepinephrine. That is not going to improve flow, but you can improve flow by giving vasodilators. Why? This is a normal heart. In the x-axis, you see preload and afterload, and in the y-axis, you see stroke volume. A normal heart is preload dependent. That means if you increase preload, stroke volume goes up. If you give a vasodilator to a normal heart, the blood pressure will drop because you decrease preload. However, if you have a failing HFrEF ventricle, so a ventricle which is dilated and not pumping well, these patients are afterload dependent. And if you then give a vasodilator, you decrease afterload, therefore you increase stroke volume. So afterload reduction works really, really well with vasodilators in failing HFrEF ventricles. Why only in HFrEF and not in HFpEF? Because afterload in HFrEF is determined by wall tension. And if you have a dilated ventricle, you have a very high radius, you have a low wall thickness, and therefore a high wall tension. So vasodilators, especially nitroprusside, which is a very cheap agent, works extremely well to increase cardiac output, to increase flow to the kidneys, and to decrease central venous pressure. How do you give nitroprusside? The drug costs €5. You give it via a continuous infusion. You only measure blood pressure, and your nurses go up with the dose up to 400 micrograms every 15 minutes, and they titrate the drug up to a mean arterial pressure of around 60. Please use the agent. It's extremely effective in failing HFrEF ventricles. Which are the other diuretic agents? So you give furosemide up to 200 milligrams 3 times a day. But what are the other agents? The first one is spironolactone. This is the Athena trial. They tested usual care, which was 25 milligrams of spironolactone versus 100 milligrams of spironolactone in acute heart failure. If you increase the dose, go up to 100 milligrams, you will not get more patients dry. So spironolactone is very important. You should give it to everybody, trial 25 milligrams, but increasing the dose is not going to make you pee better. So spironolactone is not an agent that you can use to improve diuresis if you give it more than 25 milligrams. Thiazides have a class 2A recommendation in our current guidelines. There is only one trial that looked at thiazides prospectively in a double-blind manner, and it was the Chlorotic trial. Chlorotic compared hydrochlorothiazide versus placebo. And you see, if you give hydrochlorothiazide, you have a little bit more weight reduction in patients who received hydrochlorothiazide in the primary trial results. However, the investigators also published a sub-analysis, and there they show that if you have a low GFR, that hydrochlorothiazide does not lead to more diuresis, does not lead to more rate reduction. And that is a problem because you need thiazides, especially in patients with low GFR. And in the ones with a low GFR, the drug does not seem to be very effective. The second problem with thiazides is that they have a very high likelihood to cause hypokalemia. These are data from chlorotic, and what you see is that 50% of the patients in chlorotic who received the thiazide actually developed hypokalemia, potassiums below 3, and this is dangerous. So be aware that if you use a thiazide, that you also provide potassium supplementation to actually prevent significant hypokalemia from occurring. What are the other options? Well, we talked about the nephron, which is a very long tubule. We talked about loop diuretics, we talked about thiazides, and we talked about MRAs. All these agents work in the distal part of the nephron. And remember what I told you before, that most of the sodium is reabsorbed in the proximal parts of the kidney. So why don't we give an agent that blocks proximal sodium reabsorption? And of course, the one that we have are SGLT2 inhibition. SGLT2 inhibitors are chronic drugs. We should give them to everybody lifelong. And SGLT2's inhibition, they do not increase sodium excretion. They cause an osmotic diuresis, but they do not increase natriuresis. So SGLT2s are not agents we're going to be using in the future as acute heart failure drugs. They're chronic heart failure drugs. What is the other option? Well, the other option is acetazolamide. It's a very old diuretic agent that blocks carbon anhydrase in the proximal parts of the kidney, therefore blocking the sodium proton exchanger, leading to an impressive increase in sodium excretion. So if you combine diuretics, loop diuretics with acetazolamide, you can actually double the amount of sodium excretion. This has been tested now in the ADFOR trial. ADFOR was a prospective, multi-center, randomized controlled trial where we compared standardized IV loop diuretics plus placebo versus standardized loop diuretics plus once daily 500 milligrams of acetazolamide. So you just add acetazolamide once daily, 500 milligrams intravenously. The primary endpoint of our trial was, is your patient dry? Dry meaning no edema, no pleural effusion, and no ascites after 3 days of consecutive diuretic therapy. This is a very important endpoint because it actually is the endpoint that we used, and it compares to a recommendation in the guidelines that you have to get rid of congestion. The primary endpoint was highly statistically significantly positive for acetazolamide. Number needed to treat of 8, 46% higher likelihood that you would get patients dry if you added once daily acetazolamide. We also looked at the moment of discharge, and at discharge you could still see an impressive improvement in the number of patients who were dry if they were treated for 3 days only with acetazolamide. Number needed to treat of 6. So you have to treat 6 patients to get 1 more patient dry, which is very low number needed to treat. The drug costs 4 euros per day. So 3 days times 4, that's 12 euros to actually save 1 patient from congestion. Why is the drug so effective? Well, it's because of what I told you before. If you give something that blocks proximal sodium reabsorption, your loop diuretic will become more effective. So what we saw was that we saw an incremental benefit of the agent over consecutive days just because of the reason why this drug is actually so effective. It blocks proximal sodium uptake, and therefore loop diuretic resistance will not occur because you deliver more sodium, more water to the distal parts of the nephron, exactly at the site where loop diuretics will work. So this is the way I look at acute heart failure. What do I do in the acute phase? I give an individualized natriuresis-based loop diuretic dosing. I always combine this with acetazolamide once daily if my patient was already on a loop diuretic at home. And once my patient is dry, I switch him to an oral loop diuretic and I add an SGLT2 inhibitor. I try to uptitrate neurohormonal blockers in everybody. I screen for comorbidities like iron deficiency, hyperkalemia, and once in a while we send patients for inotropes or for mechanical circulatory support, but we often still use vasodilators, especially for advanced HFrEF patients with low cardiac outputs. When do I use a thiazide? I only use it in patients who are diuretic refractory on acetazolamide and on high dosages of loop diuretics. I don't use this as a first-line strategy because acetazolamide is just a lot more effective in treating loop diuretic resistance. I thank you for your attention, and if you have any question, you can just ask me.
Well, thank you, Wilfried, for this excellent presentation as usual. And we pass to questions. I will see in the chat if there are any questions. So please, have you any questions for Wilfried? First of all, I would like to ask you, Wilfried, about this protocol of the European Society Cardiology. How to evaluate the response to diuretics, and what's the duration of the response in general, and for example, in our practice, we use usually the Karas HF, the Karas heart failure. So, what's your opinion about that?
Yeah, so I think what we propose, and it's also now in the EAC guidelines on heart failure, is that you measure either urinary volume, which should be at least 100 cc's per hour, or you measure urinary sodium. And in my experience, and in many centers' experience now, it's just easier to measure urinary sodium than urinary volume, because in Belgium, nobody wants a Foley catheter anymore. And if I give patients a bucket in which they have to pee, they don't do it. So, but if your nurse just takes one sample of urine and she measures the urinary sodium concentration, it's very easy to read it and then change the diuretic dose. So if they don't reach the threshold of urinary sodium, which should be at least 70 millimoles, then you already have to increase the next dosing of your loop diuretic already after 6 hours. So we tend to keep on doing that for 2 to 3 days. So measuring urinary sodium and measuring urinary volume. But the experience is that if you in the first day reach a good diuretic response, that patients will continue to have a good diuretic response. However, if you intervene very early on, already after the first dosing of loop diuretics, then you can change the outcome. If you don't do that, if you don't measure anything, you have many patients with loop diuretic resistance who will never be dry. So the golden day is the first day. It's the first day that will make the difference towards a patient with diuretic responsiveness or with diuretic resistance. And if you have a patient with diuretic resistance, you have to act immediately upon what you see. I don't understand why people are not doing this. It's like if you're faced with a patient with a myocardial infarct, you put in a stent and you measure the TIMI flow. If you're faced with a patient with hypertension, you give them an antihypertensive agent, you measure the blood pressure. But with diuretics, we don't do that. You just give a diuretic and then you wait and you don't do anything. So we have to change that practice. You have to assess the diuretic response as soon as you give the agent.
Good. And what about the patients with high doses of diuretic, for example, more than to 200 milligrams per day. How to manage these patients?
Yeah. So the maximum dose which I would advocate now with loop diuretics is 3 times 200 milligrams per day. If you are above 3 times IV 200 milligrams per day, you really have to add other agents. And of course, the first agent I would think about is acetazolamide. If your patient is still diuretic resistant under 3 times furosemide, 200 milligrams, and acetazolamide, then you might think of a thiazide. Thiazides are effective if your patient is on chronic high dosages of loop diuretics, because then they have distal hypertrophy. If your patient remains diuretic resistant despite furosemide and acetazolamide and a thiazide, and you already thought about vasodilators, that is a patient that we would consider for ultrafiltration. So we only use ultrafiltration if we have given all the 3 diuretic agents and also thought about vasodilators.
Yeah. For example, unfortunately, in our country, the acetazolamide is not available. So it's
but I think you have it orally. Don't you have it orally?
Orally, yeah, orally. But
you can
I
also
think it's not very effective.
Yeah,
Than
it is. No, it
the
is. So in the trial, we use it intravenously, but there have been now 3 smaller studies, one in Spain, one in Poland, one in Korea, where they tested the oral formularium, and it also seems to doing their job. So then you give twice per day 250 milligrams. So the tablets are 250 milligrams. So then I would give it twice per day, 250 milligrams in the morning, and then when you give the next diuretic, let's say after 6 or 8 hours. So you can also use the oral formularium. It seems to be effective as well.
Yeah. There are some questions in the chat, so let me.
Yeah, I see that about
Yes.
hyponatremia.
You see, yeah.
Yeah, I see
For
it. So
example,
the hyponatremia one is an intriguing one. So hyponatremia, if you see that, you have to distinguish between dilutional and depletional hyponatremia. So you first measure the oncotic pressure to make sure it's really in hyponatremia. So you need to have a low oncotic pressure, otherwise there is no hyponatremia. And then depletional hyponatremia means you don't have enough sodium. That only happens in chronic heart failure patients who are on thiazides. It normally doesn't happen in acute heart failure. In acute heart failure, it's mostly dilutional hyponatremia. That means that patients have too much sodium, but even more water retention. So that's the one what I showed in the beginning. They have a lot of ADH secretion. So if you're faced with a patient with dilutional hyponatremia, we give loop diuretics, acetazolamide, and we temporarily stop the MRA, the spironolactone. So you stop it for a couple of days because the MRA actually makes hyponatremia get worse. The second question is about the combination of acetazolamide and thiazide. Yes, you can combine it, but I would always argue to start with acetazolamide first, and you'll see you have many of them. You don't need the thiazides, but you can combine them. That's not a problem. The average duration for heart failure in our center, it's around 5 to 6 days in Belgium. Many times patients are hospitalized longer, but that's mostly because of social issues. So if we have a very old patient population, and sometimes if they're like 80 or 85 and they're hospitalized, they get they get other problems for which we can't send them home. But for heart failure itself, it mostly takes 5 to 6 days in our country to get them dry. And the next question is about SGLT2. So I don't look at SGLT2 as an acute heart failure agent. You know, in the future, everybody with heart failure will be on an SGLT2 inhibitor. I think it's a very important agent which should be giving lifelong to every heart failure patient. And it's not really going to help you acutely to decongest patients. So if you're faced with a patient with acute heart failure, yes, I give an SGLT2 already on day 1, but it's not really going to help me acutely to get that patient dry. Is there any other question?
Yeah. For example, for the patients with worsening renal function, Are you worried about worsening renal function with escalating diuretic dose?
It depends on the diuretic response, Riyadh. So if the diuretic response is good, I don't care about worsening renal function. If the diuretic response is suboptimal, like I said, then you have to do something else. So you always have to look at worsening renal function in the face of the diuretic response. If the diuretic response is good, your patient is still congested, you just continue the same amount of diuretic. If the diuretic response is suboptimal, then you have to worry because then you have to do something in order to get your patient dry.
Yeah.
Excuse me, I have a question.
Yeah.
Do you hear me?
Yeah.
Is there any contribution in your strategy of, for example, some tools like a lung ultrasound, pulmonary echo in the treatment of congestive heart failure?
Yeah, I think it's a very good question. It's part of my evaluation if there's still ongoing congestion. So I only give diuretics to patients who are volume overload. So the examinations you were referring to, like a lung ultrasound or looking at the abdomen for ascites, it's really important. If you still see extravascular volume, there is still room for diuretic therapy. So yes, I do that. So we use a clinical exam. We use ultrasound, so a quick ultrasound of the heart, of the lungs, of the abdomen, and we use a lab result. And it's a combination of everything which we take into account to actually judge if we still need diuretics.
Why there is no place of these important tools in the European guidelines?
I think
I saw that they didn't put it in the recommendation.
Well, they mentioned that you can actually assess congestion also with these technical exams, but of course the trials that there were not that many trials, of course, with diuretics, huh? But the most of the trials never really looked at echo endpoints to assess congestion. So that's why it's not really in the guidelines. And most trials still looked at clinical examinations to actually assess congestion. But I mean, we all are physicians. We have to use our brain. And you use your brain, you use your eyesight to look at clinical signs of congestion. And of course, everybody's using some technical exams to actually assess the ongoing need for diuretics.
But I think it's very easy to practice and very important information.
I completely agree. I'm completely in line with what you're saying. I use the echo in my daily clinical practice just as an additional tool to assess congestion. Absolutely correct.
I think we can put it in the algorithm of the assessment of congestion.
Yeah, so we used it in the ADVERT. So in the ADVERT trial, we used it because we actually looked with ultrasound if there was pleural effusion or ascites. This was mandatory to be done by the investigators. So we actually demanded that they would do an ultrasound to make sure there was no ascites or pleural effusion.
Thank you.
Wilfried, please, what advice do you address to your heart failure patients concerning salt consumption and water intake?
Yeah, so in the guidelines, it's stated that you should not have an excess of sodium and water intake. And we actually are now advocating a more liberal intake. So what do I mean by that? We know that many studies now have been performed that demonstrated that you do harm if you go too low on sodium and water intake. So the current recommendation is to let patients drink according to their thirst. They should, of course, not drink 10 liters a day, but you should let them drink according to their thirst. And for sodium, we actually tell them to have a normal sodium intake. What does that mean? It means between 4 to 6 grams of sodium per day. So no excess, but no strict limitation anymore.
Important, yeah. Any other questions?
There is one about the thiazide. So yes, we still use thiazides if the GFR goes below 45. But in that chlorotic trial that I was telling you about, they used a higher dose of a thiazide, so 100 milligrams of hydrochlorothiazide in patients with a GFR of 30. And if the GFR was, let's say, 90, they only used 25 milligrams of hydrochlorothiazide. It appeared that there was no beneficial effect of a thiazide in patients with a low GFR. So do I use it? Yes, rarely, but I use a lot more acetazolamide. Can you give it? Yes. Is it harmful? Probably not, but it's not going to be so effective if they have a low GFR.
Other question, I think you answered it just now. What about the VEX ultrasound protocol to evaluate decongestion?
Yeah, I think VEXes is the same question as what had been asked before, more or less. So yes, I use echo as part of my assessment of congestion, as a hand-on, so very fast evaluation. So I think it's very valuable. Yeah.
Oh, yeah.
Yeah, I think it's okay. Thank you very much, Wilfried, for your practical talk, and we highly appreciate your presence and your presentation. We hope having you in person soon in Algiers.
Yeah.
I hope.
Let's try to do that. Yeah.
Yeah.
Okay. Thank you,
So
and have a
thank
nice
you
evening,
and
everybody.
see you soon.
Merci. Au revoir.
Merci. Au revoir. À la prochaine.